Okay, so while Helen and I are presenting the results today, it's very important that we acknowledge the considerable work that our colleagues on the research team have done. So I'm very grateful to Lizanne Dowds, NILT coordinator, who masterminded the question design and coordinated us all in that regard and did some of the initial drafting. Joanne Given, who took up the analysis, one of our ADRC research staff, and used her expertise to do some of the more complex analysis. Elizabeth Nelson, who is our Public Engagement Officer, who's been working with us on this, and Elizabeth has just recently returned from maternity leave, and while she was off, Frances Kane took on that role, and we're very grateful to Frances as well. So it's a large team. And now we come to the background. Why did we want to do this research? What is the importance of this research? So I think, as Kathy said, everyone here will recognise that we live in a world where huge amounts of data are being collected about us on a daily basis. With the total computerisation of those records and other administrative data, access to this data to improve service provision, to conduct research and to inform policy has become a very important issue, but it's also controversial. The potential public benefits of use of these data must be balanced against concerns about data security and consent. Since the public are involved in all aspects, so the public provide the data, it's our data, their taxes pay for some of the research that goes on, and they need to be involved in as beneficiaries of some of the research as well. So it's obvious that public engagement is crucial. Moreover, unless the public is effectively informed, consulted and engaged, we might face a negative backlash or breakdown in trust that could take many years to repair. So, as already mentioned, the ADRN helps researchers access de-identified data so they can carry out social and economic research that benefits wider society. Researchers can apply to the network to gain access to this de-identified data so that they can carry out social and economic research. The network collaborates closely then with government departments to make this data available, and that's usually negotiated on a case-by-case basis. In ADRC-NI, we have a public engagement subgroup, which is concerned with ensuring that the public's both well informed about the research that we're doing, but also that we understand their levels of knowledge and their concerns. There's been quite a lot of research, and in our main report we summarise some of it. There's been quite a lot of research carried out across the UK into this. Many reports have been written and drafted, and some of those included Northern Ireland. However, the majority didn't, and the most important ones in Northern Ireland used a qualitative method. So they took the opportunity to bring groups of people together to get a sense of their level of understanding, but then to tell them a bit about these complex terms like de-identified, identified, consent, non-consent, all these complications, and then ask their opinions after we'd briefed them. What we were going to try to do was to do a survey across Northern Ireland, the region in its entirety, and use a survey methodology to address some of those questions. And we felt that that was really important in this region, and I think why the HSC R&D decided to invest in us, that it was an opportunity for a relatively small region like us to get benchmark data of where understanding, knowledge is now and concerns, and then we can monitor that over the years to see how we're managing to manage all of that in an effective way. So as a member of the ADRC team at Ulster University, I'm also director of ARC and very involved with the Life and Times survey series. So it seemed to us that we had a perfect opportunity here to take a vehicle like Life and Times, which has been running now since 1998. It's an annual attitudinal survey that forms a valuable time series down through the years. And the survey is joint, Queen's and Ulster, and over the years has included a lot of different modules. In the 2015 survey, which we're reporting on, we included questions on informal care, social care, community relations, minority ethnic groups, data sharing and privacy, political attitudes and background. So the way the survey is structured funders and others who buy into a module or invest in a module have the opportunity to link their data to a whole host of other variables, and that's one of the many benefits of being involved with the Life and Times survey. And the other one is that, as we've said a number of times, our policy has been to make data available within 6 months. So by academic standards, that's still relatively quick, but the data is available, and any or all of you who are interested in using it in different ways, exploring different questions, are welcome to access that data and do that. So the 2015 survey then included a module of question and vignettes related to data sharing. Now we drew from the ESRC, oops, battery source, excuse me. I mustn't be plugged on. Oh, yeah. Sorry. I never thought of that. So we worked closely with the Dialogue on Data report that the ESRC and Ipsos Mori had published in 2014 to begin to try to design questions that might work across the general public in Northern Ireland. And we're eternally grateful to the HSC R&D group, because via their networks we were able to consult about the questions with a wide range of people who had some knowledge of the importance of this and of the complexities of the questions. But I have to be honest, this is a complicated thing to try to address in a survey format, and some of our questions, when we look at them in detail, maybe we can't be 100% sure that they were measuring exactly what we wanted them to measure, but we'll talk with you about that as well. So the questionnaire, again, available in full on the website and the questions, but basically we were interested in looking at public understanding, their trust in organisations, their views about sharing data, their views about linking data, and what safeguards, which, for example, ADRC already has a very strict list of safeguards, what safeguards people were aware of, which were important to them, and were there others. So that's what we sought to do. Very briefly, the Life and Times survey runs on a systematic random sample of addresses across Northern Ireland. So if Kathy's house is selected and I arrive at her door to interview her, I will ask to interview the person over 18 who has the next birthday. So it's a next birthday rule is how we select. The interviews were conducted between September and December last year with adults aged 18 years or over, and they were carried out face-to-face in the respondent's home using computer-assisted personal interviewing. The fieldwork was carried out for us by Perceptive Insight last year. So that's the format, and at this point I always like to thank our respondents. So we had 1,200 odd people respond to the survey. When you look at the fact that we've been doing this survey for, well, in this form and an earlier form for 26 years, there's a lot of people have contributed their time and information, and really without their support and their interest we wouldn't have that, so we're very grateful to them. I'm not going to go into all the details of the survey sample, but just to show you that 1,202 people took place, 55% response rate. Response rates are a growing concern, but we feel that's up with the norm for surveys in Northern Ireland, and perhaps slightly better than some of the surveys in the rest of the UK at the moment. When we compare against the Northern Ireland census, we can see that our findings are broadly in line in terms of gender, age, and a number of other variables that we checked for. I should also say that the results that we present today are based on both descriptive statistics and more multivariate analysis, and we'll refer particularly to some of those findings in due course. But the first question that we were interested in, and it was one that sort of was a soft entry to the survey for respondents, was one about trust in organisations to keep data securely and to use it appropriately. And if you look at this infographic, you can see that at the top, it's very encouraging to our GPs to know that over 90% of respondents have faith that, that GPs will keep the data secure and use it appropriately. Very high levels as well for the NHS in general at 86%. This drops slightly when we come to consider government departments, but still almost 3/4, and slightly less again for academic researchers in a university. But it's very worrying to note, and perhaps not unsurprising, that when we look at charities and their ability to keep our data secure and use it appropriately, only 51% expressed trust in charities. And that dropped very dramatically to just 40%. So 4 in 10 people have trust in our commercial organisations to keep the data secure. Now, we don't have time in a short presentation like this to go into all the multivariate findings, but I'm just going to mention a few things that struck us, some of which we can hypothesize about as to why they might be, and others that we don't really quite understand. But when we looked at the level of trust within different socio-demographic groups, we find that it tends to be similar with regard to academic researchers and charities, but opinions are split when it comes to trust in the NHS, government departments, GP and commercial organisations. So as I say, I'm just giving you a few examples. So for example, women tend to have more trust in the NHS, government departments and GPs than men. Protestants tend to be more trusting than both Catholics and those of no religion. Trust in organisations varied with political identity. Strong nationalists were markedly less likely to trust the NHS and government departments, with 63% reporting that they would trust the NHS, compared to over 80% of all the other political identity groups. So that's one issue. Another finding that we were interested by was that respondents who reported that they had caring responsibilities were less likely to trust their GP surgery to keep data securely and handle it appropriately. And that's an interesting one that we need to talk about and think about a little bit more. But in general, trust in organisations appeared to be unaffected by respondents' education, their religiosity, that's as measured by church attendance, health or disability, apart from when the other factors above were taken into account. Interestingly, and we find this with a lot of the attitudinal data, respondents who had lived outside Northern Ireland for 6 months or more did evidence a slightly greater trust of academics, which is possibly reflecting that some of those may have actually been out of Northern Ireland to attend university or something like that, but we're not sure. So that's trust in organisations. The next thing we were interested about was what concerns people had about how organisations use the data they keep about people or the information they keep about people. So my little person here is flagging up the key finding. 42% of our respondents reported concerns. So 4 out of 10 people had major concerns about the data. Of those people, we have an image here of the things that they were most concerned about. I think they'll use my information for other purposes that they won't tell me about. 70% of those with concern were concerned about that. They might lose my information to hackers, 62%. They might lose my information by accident. I don't think they will use the information for my personal benefit. I don't think I would be able to delete my information if it's wrong. I don't trust them to keep accurate records about me. I don't trust them at all. And very worryingly, a fifth of people who with concerns thought that my personal information may be used to discriminate against me, which I thought was a very interesting finding. Now, consistent with our previous findings on trust, the same groups of people tended to have concern. Men, those of no religion, those of strong nationalist political identity, were more likely to say that they had particular concerns. Graduates emerged as a group with a higher level of concern as well, but those living on the farm or in the country were less likely to express concerns. And I'm not going to go into all the figures in that. This is just to give you a sort of a little flavour of the overall findings. So then one of the things we were interested in knowing something about was the electronic care record that was introduced to Northern Ireland in 2013. This is a new computer system that brought together every patient's care record so that health and social care staff could access all relevant information, even if treatment had been in a different hospital or another part of the service. So it contains details of lab tests, x-rays, referrals, investigation requests, appointments and discharge letters. And I'm sure those who argued to have this introduced will be very pleased to note the overwhelming support for the electronic care record here. 98% find the system acceptable in an emergency situation, but that remains as high as 96% when we're in a non-emergency situation. So I think that's very supportive of care for service provision within the health service. Okay. Then we moved on to a slightly more sensitive area, perhaps, the sharing of GP records outside the NHS. And this is not as palatable to the public as the electronic care record. This is where the question design got quite complex, and the caveat here is we had to go with a version of a question, and as Helen will demonstrate later, sometimes the question asked may be influencing the results. But basically, respondents were presented with a number of different scenarios. The first one, which involved the routine passing of information to benefits offices about people with a long-term physical illness. So the question, I'll read it out. Suppose GPs were to be allowed to share information about patients to help improve services provided by another government department. Okay, so that's one long sentence for our respondents to pay attention to. For example, if they routinely passed on information about all people with a long-term illness like severe arthritis to the benefit offices so that those people could be encouraged or helped to apply for disability benefits, do you think that this should be allowed? So you can see that's a complex question to be asked of a member of the public, and a lot of things they have to think about there. So what we found in response to that was that 80% thought it would be acceptable to pass on information about people with a long-term physical illness to benefits offices so they could be encouraged or helped to apply for disability benefits. So 80% thought yes, but of course that means 20% thought no. So you have to bear that in mind as well. We then changed the scenario to one of mental illness. What if the long-term illness was a mental illness? Do you think GPs should be allowed to routinely pass this information on to the benefits office so that these people should be encouraged or helped to apply for disability benefits? The percentage who thought it was acceptable here dropped to 71%, and those who were unhappy rose from 20 to 25%. So clearly the sensitive nature of mental health issues is impacting on people's willingness to allow the sharing of GP records outside of the NHS. Finally, we changed it to people outside government departments. What about allowing people outside government departments to see health information? For example, should GPs be able to routinely pass personal health data onto schools about health conditions like diabetes or asthma that might affect a child during the school day? Do you think that this should be allowed? And you'll see here that, again, there's a drop in terms of the number of people who think that that would be acceptable. 67% thought it would be acceptable in that case, and 27% thought it would be unacceptable. So the scenarios presented reveal quite different results for physical illness, mental illness within government departments, and then moving on to outside government departments, there's a lower level of acceptability again. Okay. So I'm going to finish at this point and hand over to Helen. But all in all, then, what we're seeing at this stage is that there are large numbers of people who find these types of data sharing acceptable. But there is a substantial minority of people who would not be happy with this. So I'll now hand over to Helen, who's going to talk about health data for use by academic researchers.
Thank you, Gillian. Gillian's just covered the results of the survey in terms of people's trust in organisations and their support for data sharing within the health service and between the health service and other government departments. And that is data sharing for operational purposes, sharing identified data that will help improve services for individuals, and there's an element of personal benefit in that as well. But now I'm going to look at the use of data for research, which was covered in this survey as well. And in that case, the data may be identified or de-identified, and we're using de-identified and anonymized sort of synonymously today. It may be used with or without the individual consent of participants. It may be with a variety of data security or confidentiality safeguards in place. And it may be for different degrees of perceived public benefit, but almost always not for individual benefit. So the survey set out to tease out these issues. So the first question that was posed in this research series of questions: suppose some university researchers are studying the causes of Parkinson's disease. They are allowed to see bits of health records, including medical information about patients, as well as their age, sex, and occupation. However, they are not allowed to see names, addresses, or postcodes. But the researchers are very keen to know roughly where patients live, because some people think that there's a link between Parkinson's disease and living near fields where pesticides have been used. So 87% of people, when asked if it should be definitely or probably allowed, agreed that NHS staff could link postcodes to agricultural data, then remove the postcodes and pass that, therefore, completely de-identified data to researchers. 60%, a lot less, but still the majority, said that NHS staff could pass the patient's postcodes, not the names and addresses, just the postcodes, to researchers so that the researchers could link that to agricultural data. Then there was another example in the same line. And suppose researchers wanted to find out if babies born prematurely did less well at school, so that in future such children should automatically be considered for extra help in the classroom. If the people who keep hospital records link them to school records and pass the researchers this data without names or addresses or other identifiers, then the researchers can look at the patterns in the data. Do you think that this should be allowed? In this case, 73% said yes. And what's interesting is that it's very similar in terms of de-identified data. Both are de-identified data examples to researchers. 87% said yes to the first scenario, and 73% said yes to the second scenario. So what's different about these two scenarios? A number of things. The second scenario is about children. And there's some previous evidence that people are keener to protect data about children. And in fact, in some of the data that Gillian showed, that was coming through potentially as well. It involves linking not just to general agricultural data, but to individual school records. So more personal information is involved. It involves transferring school records to the hospital for linking. And perhaps people are not so sure either what is actually in their school records, and they do have a better appreciation what's in their health records. The question itself, which referred to research about whether being born prematurely has an impact on school performance, is also perhaps of lesser perceived public benefit. So there are lots of differences between these two examples. We can't tell what was weighing on people, but it does show you the attitudes to data sharing are very situation specific. Depending on the complexity of the scenario that you offer people, they may have different and very rich responses. So the 1%, 73%, actually is the summary of a very rich set of complex responses to the problem posed. So we then asked people about the need for consent for the sort of data linkages for research we had just described. So they had somewhat in mind those examples that I've just showed you. People were asked to choose between 3 statements. They could only choose one of these statements, which one they thought was most closely represented their opinion. And the population, as you can see, divided 3 ways, 30%, 34% and 31%, fairly evenly. And I think possibly you can't read the white writing, but I'll read out the statement. So 30% said, it isn't necessary to ask for consent for linking data in these ways, as long as there is a guarantee that nobody will be identified. So they're the most liberal about data sharing. 34% said, you should always have to try to get consent when you can, but if the difficulties are too great, important research should not have to be abandoned for this reason. And 31% said, you should always have to ask for each individual patient's consent before linking their data with anything else, and you will have to abandon the research if there are difficulties contacting people. So that's clearly the most severe position on consent for data sharing. Now, as Gillian said, we had all sorts of other information about people, and so we were looking particularly at that more severe opinion at the bottom there, the 31%, to see who was expressing that opinion particularly. And it was more commonly expressed among those who gave their political persuasion as strong nationalist. It was more commonly expressed among those of no educational qualifications. By the way, these variables were put in a multivariate analysis for those interested in that, and they were independent of each other, independently associated to attitude to consent. Women and those of no religion and owner-occupiers were less likely to have that more severe attitude to consent. We were also interested in the middle category, those who thought one should judge depending on the difficulties. You should try to get consent, but you shouldn't abandon research if it's too difficult. And that was particularly popular among graduates, who were also least likely to give the bottom opinion there among the three. So then we also looked at opinions to consent in the light of what people had already answered about trust in organisations, as you had presented to you earlier. And although most people said, as you remember, that they trusted the NHS to keep data securely, by the way, they don't trust, this isn't trust the NHS in terms of medical care, this is just trust the NHS to keep your data securely and use it appropriately. It's just trust in the data keeping properties of these organisations. So of that fairly small percentage who said they didn't trust the NHS, a large proportion thought that you must always ask for consent and otherwise abandon the research. And similarly, a large proportion of those who didn't trust government departments, 43% for academics, 37% for those who don't trust commercial organisations. So clearly, attitude to consent is linked to trust in organisations to keep data securely and use it appropriately. So we also asked the survey participants about whether they thought that various safeguards are important when personal information is used by researchers. All of those safeguards we asked about were thought to be important by the vast majority of people. As you can see here, a scale to 100%, everything is over 70%. These are all safeguards that are actually in operation at the moment in the Administrative Data Research Network, which suggests that the efforts being made in putting these safeguards in place and the resources being put into that are well justified. And they're listed in the order of support in this slide. So at the bottom you see over 90% that researchers should be vetted, that identifiers must be removed from the data, that research must have a clear public benefit, and that there are penalties if researchers breach data security. Slightly less, but still very much thought important. Official approval for research projects, research done in dedicated, secure data centres, and the statistical results made public. So huge support for those sorts of safeguards. We were also interested to know the extent to which people think that de-identifying data is enough. So we asked at the end of the survey whether they agreed or disagreed with this statement. The statement was, even if you take the names off patient information, you can often still tell who it is from all the other information that is there. And 46% of people agreed with this statement, suggesting that they would like extra safeguards. And in fact, the ADRC, for example, does have extra safeguards in place to address this concern, that if you take the names and addresses and postcodes off, you may still be able to re-identify. So there's an extra level of safeguard. So, as you've already heard from Gillian, people showed less trust in commercial organisations. And this was also reflected in their attitudes to safeguards. 50% thought commercial organisations should have more safeguards than academic researchers. People were also asked a series of questions about specific scenarios, and the scenario chosen was one which probably everyone would agree is of great public benefit, a cure for Alzheimer's. So they were given a series of statements to agree with, 75% or disagree with. 75% agreed and 13% disagreed that commercial organisations should have access to patient records, as we will all benefit from a cure for Alzheimer's disease. 26% agreed, and 50% disagreed, that they wouldn't want commercial organisations to get access at all because they should pay for all their own research. 57% agreed, and 22% disagreed, that commercial organisations should pay a fee to get the data, as they will make a profit out of any new drug. So this is in the context of an example probably almost universally agreed to be of great public benefit. But later, near the end of the survey, people were asked whether they generally agreed with a statement that wasn't linked to any particular example. And the statement was, I don't want commercial organizations to be able to use my personal information at all. And in that case, not linked to a specific example, 39% agreed with that general statement, which seems less supportive than in this Alzheimer's example. So we're dealing with a complex issue, and attitudes depend on specific situations, so general answers can be quite difficult to interpret. For comparison, by the way, to the 39% who answered that they didn't want commercial organizations to use their data at all, 16% said that they didn't want academic researchers to use their personal information at all. Near the end of the survey, we asked people if they agreed or disagreed with this statement. If personal data can be made anonymous and a person's right to privacy maintained, then the data should be used where there is a benefit to society. And there was 85% agreement with that statement. So despite the 30% of people who thought consent was always necessary, even if you had to abandon the research, this suggests that the vast majority of people want data to be used for public benefit and are more relaxed about it if assured that the data are anonymous. But you can see, as Gillian was saying, that it's really very difficult. There are so many variables here to measure public attitudes in a way that you can definitely interpret what people are thinking that the scenario really means. So, in conclusion then, we found in this survey that the public overwhelmingly do support using data for public benefit. However, public support for data sharing is linked to 3 domains. It's linked to trust in organizations, to data protection measures, and to perceived public benefit. If you reduce or take away any one of these, then public support falls. And conversely, if you put all your energy into one of these domains but not in others, then it will not be enough to secure public support. So we have here, we think, a way forward in Northern Ireland, and hope that a repeat survey in a few years' time will reflect the progress that we've made in this area. So that's all we're going to say about survey results, but we're absolutely delighted, as Gillian has said before, that Roy McClelland who's been for many years the chairman of the HSE Privacy Advisory Committee, is going to comment on what these results mean to the policy developments in Northern Ireland. Thank you.
First of all, I would like to acknowledge the fine work that has gone into this study, this survey. I'm privileged to have the opportunity to form a response. We have today for the first time objective information on Northern Ireland's public attitude to sharing their health information. And I'm sure I speak for all of you when I say we are grateful for this report and for all the work that has gone into it. And certainly our thanks are owed to Professor Robinson, Professor Dolk and your team for this work. In my response, I would like to respond to 2 matters. On several of the findings which caught my attention, and second, on the context of this report. First, the findings themselves. On a personal note, particularly in my role as Chair of Privacy Advisory Committee, the whole survey is of significant interest for our committee. Secondly, the survey has helpfully separated consideration of public attitudes to the uses of their information for direct care and other possible uses. On direct care, 2 matters caught my attention. As you've seen, the report provides evidence of a high level of trust invested in healthcare professionals and in the systems providing direct care in our trusts and in primary care. I suggest that such trust is fundamental to the effective delivery of modern health care, particularly typically multidisciplinary in nature these days. That said, I note a significant unease around sharing information outside the health and social care community. Also unease about sharing sensitive information such as mental health information. In terms of statistics, you're getting a low-pass filter version of the very thoughtful and in-depth analysis that you realise the researchers have achieved. But I'm trying to get what for me are the main signals and messages out of this. Turning to uses of patient information for health and social care purposes beyond direct care, commonly referred to as secondary uses, I would like to comment on 4 of the findings. The survey reports a high level of public awareness of the potential benefits of health and social care information for, among other purposes, but especially health and social care research. Also, a strong public support for using such information for such purposes. But there are clear caveats here, as you've heard. There are significant concerns around issues of control of one's information and also issues around security. The survey showed a large number of people have indicated personal identifier information should not be used for such research, however worthy, in the absence of consent, high standards of security, and in the absence of clear sanctions in the setting of breaches. Now, on the issue, I beg your pardon, I've gone a little too fast. See if I can get myself out of this. I just need to get back onto my PowerPoint.
That's it, sorry.
Yes. On the use of de-identified data, there are several issues in the findings. First, a substantial number of people would wish to have consenting arrangements for use of linking data sets for research, on the face of it, even of anonymised information. The table giving this message is clearly here, where Professor Dolk has already pointed to the 31%. You should always have to ask for individual patients' consent before linking their data. And this is set in the context of the statement above, where it isn't necessary to ask for consent provided there's a guarantee that nobody will be identified. However, the consent question itself in the survey followed 3 different scenarios. Now, in the one scenario where the data was being de-identified at source, you'll see quite a substantial majority actually gave a high level of endorsement. Whereas in the scenario that has been referred to, where the researchers themselves were doing the linking and therefore accessing patient identifiers, admittedly only postcode, but that is an identifier, the level of endorsement was much lower. Now, it's quite possible, and both team leads have pointed to the complexities and the difficulties of interpreting data, but this very scenario situation may itself influenced the response to the question on consent itself. But then again, on the research question direct, I'm quite good at getting myself into. Thank you. That's it. A substantial minority, 16% of people, have indicated a reluctance to allow information to be used for research, full stop. Perhaps public concerns reported in the survey, and you've heard about them, around re-identification, security, improper uses, or the uses by commercial organisations, as the lower statistic points to, may be feeding into some of these negative responses. And I think consistent with that is the high level of endorsement, 85%, to the statement, if personal data can be anonymised and a person's right to privacy maintained, then the data should be used where there is a public benefit. And only 4%, as you can see, disagreed to that. I think this is a very important signal. So, standing back from the detail, even further back from the detail, 2 points. First, I think the survey points to important work in drawing all of these matters to our attention. As citizens, as members of the health and social care family, including those relying on patient information for purposes other than direct care. But second, a survey as such cannot do all the work. It draws attention to where other work needs to be done. Also, the findings themselves need to be considered alongside other evidence on public attitudes to data sharing. And this brings me to a brief consideration of the context of this report. Now, in Northern Ireland, we have a code of practice on confidentiality. We have personal data guardians in every trust. And we have Privacy Advisory Committee at regional level, and a significant amount of interaction between all three of those. The public, I expect, are mostly unaware of these governance arrangements around confidentiality within the health and social care services. We have an honest broker service that allows access to de-identified information for important and essential health and social care uses, and for research which has received ethical approval. And we have a Health and Social Care Act, though it hasn't yet been implemented. Nationally, in May of this year, the National Data Guardian for Health and Care issued a report. And then, underpinning all of these, we have the Data Protection Act, the Human Rights Act, the Common Law Duty of Confidentiality. Now, in finishing, I would like to comment on the two new kids on the block, beginning with the Data Guardian's report. Now, of relevance for today's event, Dame Fiona Caldicott concluded that the case for data sharing still needs to be made to the public. And I believe this is a very important message, not least because of today's report and the findings therein. And in recommendation of her report, she states, there should be a new consent opt-out model. Now, this is to allow people to opt out of their personal identifiable information being used for purposes beyond their personal care, with certain exceptions, which we needn't take on board just at the moment. But that said, also, the evidence-based sessions for the Data Guardian's review indicated that the public is broadly content for their anonymised information to be used for health and social care purposes beyond direct care. And I think this coheres with the survey question, where you have this very high endorsement and a very low resistance to such uses. The other arrival on the block is our new Health and Social Care Control of Data Processing Act. Now, significant for today's consideration, and this is written in legislation speak, so it's a bit dense, but essentially the committee which will implement the regulations ultimately must arrange for the dissemination of such information as it may appear to be appropriate to the public about the operation of the Act, and in particular about the rights of relevant persons regarding the process of their confidential information. This, I believe, is fundamental to what the Data Guardian referred to as making the case for data sharing. The other piece from the Act that I think is also very relevant today is that the circumstances in which the committee may authorise the processing of confidential information shall not include where that person has made representations to the committee that that person's confidential information should not be used. This is opt-out in the legislation. So we have in legislation for the people of Northern Ireland two important provisions that the National Data Guardian is seeking to achieve through a policy report. By way of conclusion, as the survey states, that for any use, all uses of health and social care information, public confidence is critical. And this has been a guiding principle for the work of the Privacy Advisory Committee over the past 10 years. But to give the public the last word, specifically their response to that final survey question which you've seen, for any proposed uses of patient data for health and social care purposes not directly related to their care, there is strong endorsement for the statement: the right to privacy has to be respected above all else. This, I suggest, are two of the key high-level messages coming out of this survey. Thank you.